Well, so today is about solutions and innovation. So we're going to switch to the local context. I know, first of all, thanks to Larry and to FMEC for coming to Providence. We've wanted you here for decades, so it's thrilling to have. And also, we want to present what's happening on the local scene. You know, I often tell my family I go to a lot of great conferences, beautiful places. I sit in rooms without windows, and then I don't even know where I've been. So we're going to give you some local sense of what are some of the solutions we are trying in the great state of Rhode Island. Who's never been to Rhode Island before? Okay, well, you have arrived at the best state in the union, state of one, we call it. It's really a test tube state. It's 1 million people, 1 hour at every corner by car, one city that stretches from Pawtucket with Providence and DeVille down to Cranston and Warwick, one medical school, even though Michael would like two, but only one medical school, one Department of Family Medicine, see the same 100 people wherever you go. So it's a great place for solutions. This is the state that gave you the primary care spend that's being repeated across the nation. We went from 5% to 12%. There's certainly some other efforts, including Michael's involved in with the Primary Care Trust. But I want to present two things today that we're trying to do focused on workforce. Okay. So, raise your hand. Is the crisis here in workforce, or is the crisis coming? Who thinks the crisis is here? Who thinks the crisis is coming? Who's not sure? Okay.
Yeah.
Well,
It's going to get worse. It's going to get worse.
It's going to get worse, and it's bad already. So, who has a primary care doctor in this room? Somebody who knows your name. That gives you a 19% less chance of dying, supposedly, this year. But I'm sure all of you get called by friends and family, colleagues. Do you know a primary care doctor we can go to? And there are people that are around. So there will not be enough primary care physicians in Rhode Island to serve the population. And we're going to be talking about PAs and NPs. They're not going to be here in sufficient numbers to fill the gap. That's really the conundrum. This group knows about that, of what's going on. We are in a burning platform. Access is waning in our state, and we're one of the best states for access to primary care. There's rampant burnout and moral injury. That's something that either you or your colleagues are experiencing on a daily basis. And the systems are being crushed. Our residency for 35 years with Memorial Hospital, it's not a rural hospital where 20% are at risk of being closed, but try running a hospital for folks who are underserved, we're poorly insured, in a needy community. It's really not a great thing to do. Hospital closed, we had to move our residency and our department to other places across the state. Who's from Massachusetts? So one day there was Compass Medical in 2023, a huge primary care group, and the next day it was gone. So we're fragile. And even if we look at our own state, we see that by 2030, we need 100 more physicians. This is just physicians who are providing primary care. And the bad news is we're not going to be training them, and they're not going to be served by NPs or PAs that are coming out. I did a look at number of positions by specialty in Rhode Island. We have about 750 GME slots, about 221 careers in 2021. And this gets into what we sometimes call the dean's lie. So the dean's lie is that, and now that I'm dean, that's kind of, it's a non sequitur, but we have internal medicine, pediatrics, and family medicine. Those are the numbers of positions that were offered in 2020. You can see that it's about 45% of what's being offered in general in terms of residency positions, and that's what often we hear quoted. So 45% who can go into primary care. But when you drill down to how many are actually going into primary care, it's an incredibly small number. So in 2020, we found that 35 practicing primary care GME grads from a total of approximately 220 residency grads in general. So for that year, it was 16%. And when we look what's happening in 2023 at the current data, I'll just refer you to this top line. The number of trainees who might be in primary care specialties, so IM, FM, Med Peds, and Pediatrics. Only 43 trainees are entering primary care, and only 18 are staying in the state. When we look at what's happening for PAs and NPs, it's similar. So we're training small numbers in primary care, and in our little state, we're not holding on to people. And I imagine that the picture is similar to where you're at. So who's going to save the primary care workforce? Well, since I was in medical school, and that's a long time ago, the notion was that PAs and NPs were going to swamp the field. And you can see that we actually have relatively high numbers of PAs, both in the state and throughout New England. But when you begin to see where they're going, they are not going into primary care. Similarly with nurse practitioners, there's 1,333. They, at least many are in primary care in some sort of setting, F2HCs, CHCs, hospital-based clinics, 70%. But when you look at the number of graduates that are coming out, 20 to 30 from the University of Rhode Island, from South Virginia, 7 to 10, going into primary care, they too are not going to meet the primary care needs of the future. And this is somewhat of an extrapolation, and you may have seen that we're actually increasing the red line all physicians, but what's happening across the country is we're increasing the number of not primary care physicians, where the number of primary care physicians, whether it's PAs, NPs, or MDs or DOs, we're just barely holding our own. So the future for workforce looks pretty bleak. Why does this matter? Well, you know the data that when you add an FP per 1,000 population, you have less disease with pneumonia, heart attack, and heart failure. We save money. I sometimes use the metaphor, we're like Bud Light. Anyone know the tagline for Bud Light? Less filling, better taste. Okay, so family medicine, primary care. What do? We are better in terms of outcomes, and we cost less money. It's remarkable. But you saw that, I'm sure the study that we even helped with mortality, what was one of the reactions in Forbes? Does anybody actually care? And this is a graph which I sometimes show that we always need a certain percentage, a ratio of generalist physicians. It's somewhere between 40 and 55%. If you have too many generalists, quality goes down. If you have too few, cost goes up. But we are really entering a time in which we have too few, and that's a mistake that lasts for a generation. I'm not going to go through the slide, except I just refer you that the tipping point. Have we reached already the tipping point? And if we have, after the tipping point comes the abyss. Is that where we're going? So I'll just ask you to think about this to yourself, because all of you are presenting solutions. But what are we going to do about the workforce? Anyone doing anything for the workforce right now, today? Helping the primary care workforce? A lot of you are creating great places to work, whether it's Chen Med or One Medical. There's real estate options. But what are we doing about workforce? So I'm going to present two things that we're doing in Rhode Island, maybe examples you can take home. One is, how many of you have heard of the Care Transformation Collaborative of Rhode Island, formerly known as CSI Rhode Island? Well, it's a group that's convened by the Office of the Health Insurance Commissioner and by Medicaid. It includes the insurers, the providers, the public, academics, and government. And it's been a really remarkable organization that's been able to intervene to help take your mom and pop's family medicine into the modern era of PCMH, help us move towards ACOs, but also push specific initiatives on multiple fronts, whether it's integrated behavioral health or it's the use of remote monitoring for improving health outcomes. But one of the things that they began to say, and that we've been saying in this group and saying in Rhode Island, we don't have enough providers, so what can we do? So in this past several months, we've started a primary care provider task force. One of the innovations, which may or may not be an innovation for your areas, is that it doesn't just include the training directors in medicine, so IMF, MedPeds, and pediatrics. It also includes the nurse practitioner programs and the PA programs. So we're seeing this as a challenge for the wider workforce. Our goal is to make Rhode Island #1 in population health and health equity, and our objective is to build a strong and robust primary care delivery system across the state. And we're talking about, we really have to hit that at several points. We have to attract, train, support, sustain, and retain if we're going to actually have an impact. And what we've done at this point is create our strategic goals. And goal #1 has to be increased payments and incentives. We know that we're not doing well
We need to do better. We have to, number two, we have to recruit medical students, residents, NP and PA trainees to enter primary care and stay in there. That's about tuition and debt, as well as making the field look attractive. We have to increase funding for training primary care providers. Most of the providers who do train, whether it's physicians, NPs, or PAs, are doing it on their own time. So let's pay for that. Let's enhance the on-site clinical training so that we're actually training the folks in advanced primary care in the kinds of things that are happening in some of your organizations. We always want to think about diversity, equity, and inclusion, and we have to have actionable data sources. So what have we done so far? Well, we got the groups together. We've had people meet. In a short period of time, we've been presenting around the state at various forums. And at the current time, we have two proposals, one in for the governor's budget to have a $1 million fund that begins to pay for tuition for those who are going into primary care. We also have a much larger bill that we're putting into the legislature that would help to pay for training sites, pay people to train, and also pay to the full tuition for a select group of medical students, NPs and PAs who agree to stay in the state. The other thing we're doing is that under a bit of pressure about in Rhode Island, we have one medical school, Brown University, the Albert Medical School. There has been some pressure on that school to, number one, accept more Rhode Islanders, and number two, produce more primary care. So, poof, about 8 years ago, they said, let's help you create a track that not just pushes primary care, but pushes population health. And we think it's one of the answers to the problem. It's a longitudinal primary care program, and some of you were involved. How many of you are involved in longitudinal primary care training? Okay, a few people, but it's, you know, it's sprouting up around the country. But the notion being that if we want to attract people to primary care, we can't do it in the kind of rotational method where you see family medicine for 6 weeks or primary care internal medicine for 2. You need to see what's happening over time. So what we've done is create a program that we think is bold, but you can decide if it's bold or not bold. And it combines the MD program, a modified MD program, with a master's in population medicine. And what we're basically doing for about 16 to 24 students per year is to try to train them in all the things that most of you have to learn on your own. And what we're calling the product is a very vague term called Clinician Plus. So what's a Clinician Plus? Well, we want these to be great doctors, but do something else. Do something like the folks in this room are doing. It might be to start a healthcare plan. It might be to be in the health department. It might be to be an educator, a researcher. It might be to be an activist. But to get involved and to make a difference. And we want to give these students the tools to be able to do that as soon as they leave. We have lots of program objectives that are focused on both primary care and population medicine. We link together the basic science, political science, and the third science of medicine, health system science. My co-teacher is here in the room. We want them to do research on a problem that's actionable, and we want them to follow patients longitudinally. We want them to know how health policy works and to actually get involved in the state. We want them to know about how to assess the community. We train them in leadership. We don't just talk about leadership. We get them involved in health laws. And finally, we want to train them as teachers. It's exciting because it's working with something that probably all of you believe in your kishkas, in your gut, which is a socio-ecological model. We really work on the quintuple aim. We work an updated definition of primary care, which you all know, so I'll skip that. And we're trying to fill that space between the individual patient and public health. Public health is up here, clean air, clean water, initiatives that will help for, statewide. We're talking about what happens between the individual, the family, the community, the population, and then, of course, working with public health. The foundation stones are population medicine, population health, socio-ecological model, social determinants of disease and health system science. We believe in the social determinants of health, and from the get-go, talk to students about the role and really think about a new way of talking about social determinants, where health begins where we live learn, work, and play. This third science of medicine is actually critically important because we're not bad in training medical students or NPs or PA students in the basic sciences and in clinical, but all the stuff that you're doing on your own, whether it's learning how to use new apps or communicating with a team or doing health policy or thinking about healthcare finance, all the things that you have to learn on your own, we're trying to train people in that. And it's really kind of an iceberg where at the top it's the care provided to an individual patient, where systems thinking is really core to what's happening. And this is really our new model with the patient, family, and community, with the areas, the domains, whether it's value in healthcare, healthcare system improvement, healthcare structure and process, healthcare policy and economics, clinical informatics, population health, and social determinants of health, with a ring of teaming and leadership and ethics and thinking within a systems model. This is kind of our motto, this is our model, this is our paradigm, and this is what we're training the students to do. 4-year continuum, their courses are built in so they're able to do them throughout their 4 years. And some of the students even say, you know, we asked them the other day, isn't this impossible to do, an MD and a master's? And some said, no, it actually makes it easier because it's so well integrated that you're able to move from area to area without having to search on your own. Lots of leadership training, research training. In the 3rd year, they do a longitudinal integrated clerkship where they have time to learn both about medical topics and community medicine topics. Those are kind of the core areas for the LIC. Lots of opportunities for leadership who want them to get involved, and this has been an activist group. And what we found, and we're entering our 8th year, is high level of satisfaction. We've had about 115 students, only 3 students who are not able to complete both the MD and the master's. No differences in exams. We found that these students, and we've been very lucky, have been innovators and leaders. We've been graduating classes since 2019. There's been some unexpected insights. They've formed within the larger medical school a strong supportive group that provides resilience and identity. They have leadership potential that they've displayed. 3 out of the 4 last Senate presidents of medical school from this. These are involved in all kinds of activities throughout the medical school of the state. They're taking it from advocacy to kind of direct action and activism. Some of them find it easier to do the dual program than just the MD, and they've been partners in the process. Something we've added is an early action program. I know some of you are taking your kids, their kids to apply for college. So in the early action program, Rhode Island is a great state. So if you've been here for 4 years or 8 years, if you came in for undergrad in medical school, stay another 3, stay a lifetime. How many graduates do we have with the family medicine program in the room? Okay, so we have a few. So we're hoping you're here for a lifetime. But the notion being, we train these students, they're incredible. So now we save residency slots for them in FM, IM, and pediatrics. And so far, 9 have taken that up. We think this will be a banner year coming forward. And then I just want to present, and this has been, Dr. Schwarko has kind of pressed me on this one. We have a new paradigm change from an old model of medicine as a service prevention. You got to sacrifice personally in order to reduce the suffering in others, and you need to negate your personal needs. Well, that certainly worked for my generation, somewhat well. But maybe we're at the time for a new model. Lean into a model of joy and meaning in medicine. And how about establishing and keep establishing every year, every month, a work-life balance, nurture your personal needs, and prevent and recognize burnout. And then maybe great care is achieved through caring for ourselves. So we should be celebrating part-time, mixed time, personal time, and the chapters of family medicine. So I'm going to stop there. But what I wanted to present, we're having workforce issues in Rhode Island. Who's having workforce issues in their state or around the country? Everybody. We have to do things differently. So you came to Rhode Island, the greatest state in the union. 2 things you can think about taking home. One is if you have something like the CTCRI, the care collaboration group, try to get them focused on workforce, pull in your NP and PA trainees, and think about the role of the medical school. All of your medical schools should have a primary care track. It turns out nationally there's only about 30 of them, and those 30 are turning out more primary care doctors. So let's see if we can make some differences that emanate from Rhode Island.